Okay, I had to start over. I didn't have my pen light to start off with. Okay, so starting over from the top. Co-wipe, check physician orders and for allergies, assemble appropriate equipment, wash hands, introduce myself to mom and dad, and identify mom and dad and baby, making sure I'm taking the right baby from the right people to do the right assessment. Provide for privacy and educate, explain, and evaluate. So first, we are going to assess baby's vitals. We would take a temperature under the armpit or with the axillary method. I don't have a thermometer here, but we would pretend I would. And baby's temperature should be like somewhere between like 97.6, 98.6. And then we don't usually check baby's blood pressures, but I'm going to go ahead and listen to the baby using the bell of the stethoscope, listening over where I would want like the apical rate, listening for a full minute. We would want baby's heart rate to be between 110 and 160. And then I'd also go ahead and just like auscultate baby's lung sounds on the sides, all the way down. Hopefully baby would be crying a whole lot, giving me some good stuff to hear. We could listen to baby on the back as well. We'd be counting baby's respirations again for a full minute. Should be between 30 and 60 breaths per minute. And then after all that is said and done, move on to measuring baby's head, chest, and abdomen. So starting with baby's head, this would be really hard on a real baby, I can only imagine. But this baby's head is about 14 inches. Or what is that in centimeters? It's about 35 centimeters. And then for baby's chest, we're gonna look right over the nipple line. Try my best. Lift baby up for this. Bringing this around. Gonna have to lift up baby's arms to get an accurate measurement. A real baby wouldn't be able to hold their arms up like that for me, but that's okay. So baby's chest is about 30 centimeters or about 12 inches. And then abdomen portion, I'll have to have the diaper taken down. It's covering his little belly button, but we would want it to be directly over the belly button and then, or the umbilicus. And then bring baby all the way around his little tummy. If I can get this measuring tape to stay here. This is about 12 and a half inches or 32 centimeters. So that's all said and done. I'm gonna go ahead and put his little diaper back on for right now. Okay, after we have done all those measurements, then I'm gonna go ahead and assess baby's reflexes. So the first one is the startle reflex. I would just lift baby's arms up and then drop them. And I would expect baby to do that little crazy jolty movement, which is normal. Baby should be startled. We would expect that to be a normal finding. And then the next one is the Rudy reflex. So I would just gently stroke baby's cheek, and baby should turn his head towards the cheek that I stroked. And then the next one, the grasping or grip reflex. I put my little finger or something else into baby's palm, and then baby should grasp it. If for whatever reason baby didn't do any of those normal expected findings, I would be reporting that right away. Next, this is why I had to stop the last video. I didn't have my pen light, so we would be assessing baby for Perla. Just like we would an adult. Baby may not be able to accommodate and really focus on my pen light necessarily, but we would just want to make sure that his pupils, react and dilate. And then also just inspecting the mucous membranes, are they pink? Are they moist? Are they intact? And then also looking at baby's eyes, you know, is there any discharge? Are the eyes swollen at all? Sometimes I've read that like they can be a little, especially if they've had that eye cream to help prevent the infections after delivery. It can sometimes give them a little swelling sometimes. But we wouldn't want to see like any crazy discharge or it to be like super swollen, like baby's eye, like baby can't even open his eyes. That would be an abnormal finding. So we would be looking for all of that. And then also looking at the symmetry of baby's eyes in proportion to baby's head and nose, and then his ears too, especially. The baby's top of the ears, or the pinna, should be level with that outer portion of baby's eye. Usually it's pretty level. If the ears for some reason were like lower, that could be an indication of like Down syndrome or some kind of other defect. So we would definitely want to be looking out for that. Next, we would look at baby's mouth, and then normally I would put on gloves and then like put my finger in baby's mouth. Make sure baby like starts sucking. That's also a reflex that baby should start sucking on my finger when I put it in its mouth. And then also at that time you can inspect the palate, making sure baby doesn't have like a cleft palate or anything like that. And then after that is all said and done, we would look at baby's chest, making sure the chest is symmetrical. I know we already measured baby's chest, but like really making sure like that rise and fall of baby's breaths are even, and just making sure like you could even possibly like make sure like baby's chest is symmetrical, like one side isn't deeper than the other, or one side doesn't protrude more than the other. And then the next part, we could test baby's capillary refills, looking at his little fingers. Sometimes baby's fingers and toes may, you know, depending on like how soon after baby has been born, sometimes their hands and feet are more of that like blue discoloration. But we would still want to expect to see that capillary refill to happen. Next, I already auscultated baby's lungs and heart, but I didn't do baby's bowels, so we'll do that next. We would want to just listen to make sure we can hear bowel sounds in all 4 quadrants. And at this time too, we could go ahead and assess like, has baby had a bowel movement? Has baby urinated? What is that bowel movement and urination like? What's the color? Is there odor? The amount? If baby did have a bowel movement, it usually is that like dark green color. I think it's called meconium or something like that, like meconium or meconium, but that's normal for the first couple of days after baby's been born. It's like that dark green kind of color, and it tends to be a little sticky, but it shouldn't have like a crazy foul odor or anything like that. And then just making sure, you know, baby's urine, it's not like, ooh, no crazy odor, not like super amber in color or anything like that. We would just want, you know, clear or lightly yellow, and like just seeing is how much baby is voiding. And then with those bowel sounds, making sure like they're present, and that baby's not like constipated, no hypoactive bowel sounds. Next part, we would look at the umbilical cord, seeing if it needed any care, depending on how newly post-delivery we are, you know, does the cord need to be cut a little more, and does that little clamp need to be put on at the end? If not, we would just want to make sure that there's like no sign of infection, or, you know, any redness or excessive bruising, no bleeding. And if it needed to be like cleaned a little, we could with like some water, but no harsh chemicals like alcohol or anything like that. And then also we would go ahead and talk about looking at if baby had a circumcision and the care around that. This is actually a female baby, but we'll just pretend. But looking at circumcision site, you know, is there any sign of infection? Is there any crazy discharge? Is there any bleeding? Is it swollen? Making sure there's no like foul odor. And then, you know, really making sure, if, especially after baby has bowel movements and urinates, cleaning that area with warm water. And then giving that education to mom and dad as well, like, you know, just keep out for signs of infection, cleaning the area really well. And then sometimes like there's a little gauze that goes back on it after you know, every time baby has a bowel movement or urinates, the gauze will probably have to be replaced, and sometimes it has like petroleum jelly or whatever the physician orders needs to be on that gauze. But making sure that that is done and making sure mom and dad are aware of that and make sure they know they need to do that every time they change baby's diaper. Next portion, we're looking at baby. We're going to flip her over and look at her back. Making sure it's like symmetrical, and then also making sure we don't see any like major dimples or like a tuft of hair, especially kind of lower on baby's back, because that could indicate some spinal abnormalities. And then also, well, after keeping baby kind of like that, making sure that like baby moves her arms and her legs kind of symmetrically, and then, you know, making sure like her hips like don't flex abnormally or anything like that. Just making sure like her movements, while she may not be super coordinated at this point in her life, that they're somewhat symmetrical. Like we shouldn't see like one side not move at all, or like any hyperextension or anything like that. You know, just making sure everything looks even and symmetrical all throughout baby's body. And then also doing a full skin inspection on baby's body as well. Making sure it's clean, dry, intact, pink. Again, I know I said before baby's hands and feet may be a little blue depending on how far after delivery this is, but that's okay, that's normal. Just making sure the trunk of the baby is not pale or blue in any way. And then last portion, I know I talked about like making sure baby was identified properly before I took baby away from mom and dad. But if this was like a very new postpartum baby, like right out of mom, we would be putting that ID band on baby and mom and dad. So we all know this is their baby. We don't want this baby to get mixed up with anybody else's baby. And then after all that, I would go document my findings. I know we're supposed to document like an APGAR score, so I'll kind of make one up on my documentation, but that's it.